Welcome back to the deep dive. We are shifting gears a bit today. I want you to mentally step away from the noise of the daily grind. The notifications, the rush.
Joined a quiet space.
Yeah, exactly. Come with me into a different kind of space. Imagine a study. It's comfortable, maybe a little dimly lit, heavy oak desk, the smell of old paper and leather binding.
I can picture it.
On the walls, instead of, family photos or landscapes, you have these abstract, intricate prints of neural networks, dendrites branching out like ancient trees, synaptic clefts glowing in the dark.
It sets a very contemplative mood, a studious mood.
Which is perfect, because on that desk, we have a stack of absolute heavyweights. We have Casson and Trevor's Basic and Clinical Pharmacology, specifically the chapters on antidepressants and sedative hypnotics.
The classics, so clear, so well organized.
And right next to it, the Bible itself, Goodman and Gilman's The Pharmacological Basis of Therapeutics.
The ultimate source material for anyone serious about medicine. Ketzing is fantastic for the clinical scaffolding, the what and the how. But Goodman and Gilman, that is where you go for the deep mechanistic reasoning, the molecular why.
Exactly. And today, we are using them to tackle what I think is one of the most paradoxical, frustrating, and fascinating areas of human health. We are diving into Pharma 15, treating depression and anxiety.
It's a huge topic.
It is. But before you tune out thinking this is just a list of pills to memorize, I want to frame this differently. We aren't just talking about fixing a chemical imbalance. We are talking about the mechanics of restoring emotional balance.
That distinction is the core of everything we're going to discuss. It's so important. When you actually read chapter 15 of Goodman and Gilman and cross-reference it with chapters 30 and 22 of Katzung, you realize the popular narrative about these drugs.
The one you see on TV commercials.
Yeah, that one. It's
Yeah.
incomplete at best. It's not just filling up a gas tank. It's about adaptation. It's about remodeling the physical structure of the brain.
And that brings us to the hook.
Yeah.
This is the thing that has always baffled me. And I know it confuses so many patients. We have these powerful antidepressants, right? SNRIs, SNRIs.
Modern workhorses.
Chemically, they are incredibly fast. You swallow a pill, it dissolves, it enters your bloodstream, crosses the blood-brain barrier, and within hours, your serotonin or norepinephrine levels are up.
That's right. The pharmacological blockade of the transporter protein happens almost immediately. The drug binds and the reuptake pump stops working.
But, and here's a massive paradox, the patient doesn't feel better. Not immediately.
Not even close.
They don't feel the lift for weeks, sometimes a month or more. In fact, sometimes they feel a little worse before they feel better.
It is the central mystery of modern psychiatry, or at least it was for a long time.
So if the chemicals are fixed by lunchtime, why is the depression still there at dinner? Why is there a lag? That is the mystery we're going to unpack today.
And the answer to that mystery effectively explains the entire biological basis of mood disorders. It forces us to move beyond simple chemistry and look at structure, genetics, and ultimately time. It shifts our perspective from acute effect to chronic adaptation.
Okay, so here is our mission for this deep dive. We are going to synthesize the clinical clarity of Katzung with the mechanistic depth of Goodman and Gilman. We want to build a mental model of how these drugs actually work.
But we should add our standard disclaimer here. This is an interpretive synthesis. Think of this as a revision scaffold or a conceptual map. We are guiding you through these complex concepts, helping you connect the dots.
But this does not replace reading the textbooks.
Absolutely not. And it certainly does not constitute medical advice.
Of course. We are here to help you understand the mechanisms so that when you go back to the text, it makes sense. Active reading is essential. So let's look at the stack. We've got Goodman and Gilman chapter 15, which is heavy on molecular reasoning, gene expression, and that fascinating intersection where anxiety and depression meet.
Right, the deep why.
Then we have Katzung chapter 30, which lays out the antidepressant arsenal classifications, indications, side effects, very clinical.
The practical guide.
And finally, Katzung chapter 22 on sedative hypnotics, because you really can't talk about anxiety without talking about sedation and GABA.
It's a lot of dense material, but if you know where to look, there are very clear patterns that emerge. You start to see the logic.
Let's give the listener a roadmap then. What are the key pillars we want them to walk away with today? The big takeaways.
First, and this addresses your paradox, we need to understand chronic versus acute. We need to explain why antidepressants work through time-dependent neuroadaptation. We need to explain how they essentially reshape the brain rather than just providing a quick chemical boost.
That's the answer to the lag time.
Precisely. That's takeaway number one. Second, we'll look at shared pathways. Depression and anxiety often look very different on the outside. One is low mood, the other is high arousal or fear.
But pharmacologically, they share almost identical targets.
Exactly. Which explains why the same drug, like an SSRI, is the first-line treatment for both. It's a huge clue to what's really going on underneath.
Okay, that's two. What's next?
Third, we want to move away from rote memorization. We want you to view drug classes, SSRIs, SNRIs, TCAs as strategic tools. You don't just pick a drug from a list, you choose a class to shift the neural network's tone in a specific direction.
I like that. It's strategy, not a lottery.
Fourth, we'll discuss adverse effects as clues. Side effects aren't just random annoyances, they map directly to receptor pharmacology. If you understand what the receptor does, you can predict the side effect before you even open the book.
That is a huge help for remembering all this stuff. It makes it logical. And finally,
Clinical reasoning, the art of it. How do we match the drug to the patient's specific life, their body, their symptoms? Because as we'll see, no two patients are the same, and the best drug is often the one that fits the person, not just the diagnosis.
that's the plan. It's a big one. So let's get into it. Section 1, the biological landscape. We have to address the elephant in the room, the chemical imbalance theory.
Right.
You hear it in commercials, you hear it in pop culture. Oh, I'm just low on serotonin.
Yeah, that's what we call the monoamine hypothesis. It was the dominant dogma for decades. And the idea was very simple. Depression is caused by a deficiency in monoamines, specifically serotonin, 5-HT, norepinephrine, NE, or dopamine, DA.
It's a very neat and tidy theory. It makes intuitive sense. Low tank. Fill the tank. Problem solved.
It is, and it drove drug development for a long time. The logic was, if we give a drug that inhibits the reuptake of these chemicals, stopping the brain from vacuuming them up, we leave more in the synapse, levels go up, and the depression should go away.
Well, Goodman and Gilman just throws a wrench in this machinery.
Yeah. A massive wrench. A show-stopping wrench. As we mentioned in the intro, the drugs work on the transporters SERT for serotonin and NET for norepinephrine almost immediately. Within hours of taking that first dose of Prozac or venlafaxine, the amount of neurotransmitter in the synapse shoots up.
So if the low tank theory were true, you'd take your pill at 8 a.m. and feel like $1 million by noon.
Exactly, or at least a little better, but you don't. The therapeutic benefit, the actual lifting of the mood, the return of motivation, the abating of the despair, takes 3 to 4 weeks, sometimes longer.
Which tells us something profound.
It tells us the immediate boost in neurotransmitters is just the trigger. It is not the cure.
Okay, I want to pause on that because it's so important. The chemical boost is the start of the process, not the end result. So what is the cure? What is happening during those 3 long weeks of waiting?
The cure is the brain's reaction to that trigger. We call this neuroadaptation and plasticity.
Neuroadaptation. That sounds like the brain is getting used to the new normal. It's adjusting.
That's exactly what it is. To understand this, we have to look at what the depressed brain looks like physically. In a state of chronic depression or severe stress, the brain is often stuck. High levels of cortisol, the stress hormone, have actually inhibited the release of growth factors.
Growth factors, like fertilizer for cells.
Exactly. The most important one in this story is BDNF, brain-derived neurotrophic factor.
I love BDNF. I've heard it described as miracle grow for the brain.
That is the perfect metaphor. It's perfect.
Yeah.
In a depressed brain, BDNF levels drop. Without that fertilizer, neurons in critical areas like the hippocampus start to shrink. They literally atrophy.
Wow.
They lose their connections. The dendritic spines wither away. Some neurons even die via apoptosis, which is programmed cell death. The brain literally loses volume and connectivity.
That is terrifying. So depression isn't just a mood issue. It's actually a neurodegenerative state.
In a reversible sense, yes. The neural networks become rigid and sparse. The communication breaks down. It's like an ecosystem in a drought.
Okay, so that's the problem. The soil is bad. Now enter the antidepressant.
You boost the serotonin and norepinephrine. Goodman and Gilman explicitly states that sustained signaling via these neurotransmitters over time, over weeks, switches on the transcription factors in the cell nucleus that produce BDNF.
So the chemical signal has to travel all the way into the cell's command center and tell it to start making fertilizer again.
Precisely. It's a genetic change. It's turning on the BDNF gene.
Okay, let's stick with the gardening metaphor because I think it really helps visualize this. The monoamine hypothesis, the old way of thinking, says the problem is that the plants are dry, so we just dump water, serotonin on them.
Right. An immediate fix.
But the neuroplasticity model says, no, the soil itself is depleted. It's lost its nutrients. The drugs, by boosting serotonin and norepinephrine, eventually trigger the production of BDNF.
The fertilizer.
This BDNF acts like fertilizer.
Mm-hmm.
It encourages the growth of new connections, dendritic spines, and even neurogenesis, the birth of new neurons, particularly in the hippocampus.
So, the drugs don't just paint the leaves green by adding chemicals, they fertilize the soil to encourage new growth. And growing a new plant or repairing a sick one takes time.
It takes weeks. You can't rush biology. That 3 to 4 week lag is the time it takes for the signal to reach the nucleus of the cell, for the genes to express the BDNF, for the proteins to be synthesized, and for the physical structure of the neurons to remodel.
It's literally rebuilding the brain's microarchitecture.
That makes so much sense, and it also explains why you have to keep taking them. You can't just fertilize once and expect a forest to grow overnight.
Precisely. And there's another mechanism at play here too, which Goodman and Gilman highlights, regarding the receptors themselves. It involves the autoreceptors.
Autoreceptors, okay, refresh my memory. Those are the sensors on the sending neuron that say, whoa, too much serotonin out here, stop releasing it.
Right, they're the feedback loop. Correct. They are the brakes. They are part of the body's homeostasis. It's a safety mechanism. Now, when you first start an antidepressant, you flood the synapse with serotonin. The presynaptic autoreceptors detect this surge and say, system overload, shut it down.
So they panic.
They panic and they slam on the brakes. They stop the neuron from firing as much serotonin.
So the drug is trying to push the gas, and the brain is slamming the brakes at the same time.
Yes. And this conflict actually counteracts the drug initially. The net effect on serotonin release can be minimal at first.
Is that why people sometimes feel worse or more anxious in the first week? That chemical tug of war?
Partly, yes. You have this chemical turbulence, but over a few weeks of constant stimulation from the drug, those autoreceptors get desensitized. They downregulate.
So they get tired of yelling and give up?
Essentially, yes. The brakes wear out. Once the brakes are gone, the neuron can release serotonin freely, and combined with the reuptake inhibition, you finally get that sustained high level of signaling that drives the BDNF production.
So we have to wait for the brakes to fail and the fertilizer to work. No wonder it takes a month. It's a two-stage process.
Exactly. And this framework of plasticity applies to anxiety as well. It's not just for depression.
Right, let's touch on that overlap. Goodman and Gilman notes that depression and anxiety affect over 15% of the population and often co-occur.
It's incredibly common. Clinically, they often look like flip sides of the same coin. The patient is often diagnosed with both.
And biologically, they share pharmacological targets. Drugs that boost serotonin often treat both conditions.
Which suggests that while the symptoms look different, one is low mood, the other is high fear. The underlying pathophysiology involves a dysregulation of the same neural circuits. The amygdala, the prefrontal cortex, the hippocampus.
So by increasing plasticity, we aren't just lifting mood, we are helping the brain unlearn fear or rewire anxious pathways.
Exactly. We are restoring flexibility to a rigid stress system. An anxious brain is stuck in a loop of fear. A depressed brain is stuck in a loop of hopelessness. Plasticity breaks the loop. It gives the brain the biological capacity to form new, healthier patterns.
This is a perfect segue into Section 2, the antidepressant arsenal. We know we need to boost these systems to get the plasticity going, but we have different tools to do it.
We do. And in Katzung, these are categorized by their mechanism. But as we discussed in the roadmap, I prefer to think of them as strategies.
Let's start with Strategy 1, precision striking. The SSRI's selective serotonin reuptake inhibitors.
These are the household names: fluoxetine, citalopram, escitalopram, paroxetine, sertraline. They absolutely revolutionized psychiatry in the late 80s and 90s.
And the revolution wasn't because they were necessarily more effective.
Not really.
The revolution was that they were cleaner.
When you say clean, what does that mean in pharmacological terms? It means selectivity. Imagine a key that only fits one lock. SSRIs target the serotonin transporter, or SERT, and block it. But critically, they mostly ignore other receptors. They don't have a high affinity for histamine receptors or acetylcholine receptors or alpha-adrenergic receptors.
You get the serotonin boost without all the baggage from those other systems, without the dry mouth, the sedation, or the dizziness associated with those other receptors.
That's the theory. And for the most part, it holds true. That's why they are first line. They have a high safety margin, a broad spectrum of activity. They treat major depression, generalized anxiety, PTSD, OCD, you name it.
That sounds great, but they aren't side effect free. Katzung lists a few distinct ones that are very common.
No drug is free of cost. With SSRIs, the side effects are essentially too much serotonin in the wrong place. The body has serotonin receptors everywhere, not just in the brain circuits for mood.
Give me an example.
Okay, the big one early on is nausea and GI upset. We tend to think serotonin is a brain chemical, but 90% of your body's serotonin is actually in your gut. It's in the enterochromaffin cells.
And what's it doing there?
It regulates motility. It helps your intestines contract and move things along.
So when you take a pill to boost serotonin in the brain, you're also inadvertently cranking it up in the gut.
Exactly. You stimulate the 5-HT3 receptors in the stomach and gut, and you get nausea, diarrhea, cramping, just general upset. It usually settles down as the gut receptors downregulate over a week or two, but it's very common early on.
So your brain gets happy, but your stomach gets confused. That's a good way to remember it. And then there's the big one, the one patients are often most afraid to bring up, sexual dysfunction.
It is a major issue, a huge reason for noncompliance. It affects 30–40% of patients, maybe more, because it's underreported.
And what does that look like?
Loss of libido, delayed orgasm, or anorgasmia, the inability to achieve orgasm at all.
Why does that happen? Is that also too much serotonin?
It is. It's caused by increasing serotonergic tone at the spinal cord, specifically by stimulating the 5-HT2 receptors. Serotonin generally acts as an inhibitory signal on sexual reflexes. Evolutionarily, it's a satiety signal. It says, I'm content, I'm done.
So if you crank up that I'm content signal all the time,
You dampen the sexual response reflex. It's a direct pharmacological effect.
that's a significant trade-off for many patients. And what about that jitteriness or activation we mentioned earlier, that feeling of anxiety when you start?
That's the initial anxiety. Before the adaptation kicks in, you are stimulating 5-HT2 receptors in the brain, specifically in the limbic system, the amygdala. That stimulation can feel activating or anxious. It's like turning the volume up on the fear circuit before the brain learns to adapt to the new volume. It usually passes, but it requires hand-holding in that first week.
Okay, so that's the precision strike of the SSRIs. But sometimes precision isn't enough. Sometimes we need a broader approach. And our strategy 2, dual action, the SNRIs.
Serotonin norepinephrine reuptake inhibitors. Drugs like venlafaxine, desvenlafaxine, and duloxetine.
Mechanism-wise, these are blocking both SERT for serotonin and NET for norepinephrine. Why would we want to add norepinephrine to the mix? What does that get us?
Think about what norepinephrine does in the brain. It's part of the fight-or-flight system, but centrally it's involved in arousal, energy, focus, and concentration. It's a get-up-and-go signal.
So if you have a patient whose depression looks more like melancholia, low energy, brain fog, sleeping all day, what we call psychomotor retardation, an SSRI might be too subtle.
Exactly. They might feel calmer, but still unmotivated. You need that norepinephrine kick to help with the deficits in concentration and energy.
Right. And Katsung mentions a bonus feature for SNRIs that is absolutely critical in the clinic: pain.
Yes, this is a key clinical pearl. SNRIs treat pain, particularly neuropathic pain.
Why? What's the connection between norepinephrine and pain?
It has to do with the descending inhibitory pathways in the spinal cord. It's a fascinating system. When you hurt yourself, the pain signal travels up the spinal cord to the brain. But the brain also sends a signal down to the spinal cord to say, okay, I got the message, you can dampen the noise now.
It's like a volume control.
A volume control, exactly. And that downward dampening signal relies on serotonin and norepinephrine being released onto the spinal neurons.
So if you are low on those neurotransmitters, your pain gate is left wide open. The volume is stuck on high.
Correct. Drugs like duloxetine boost those levels in the spinal cord, effectively helping to close the pain gate. That's why they are approved for diabetic neuropathy, fibromyalgia, chronic musculoskeletal pain.
That's huge. If I have a patient with depression and chronic back pain, an SNRI seems like a 2-for-1 deal.
It is often the preferred strategy. You're treating both conditions with one molecule. However, there is a toxicity note here we have to mention. Venlafaxine, specifically, is associated with dose-related blood pressure increases.
Because of the norepinephrine.
Yep. Norepinephrine constricts blood vessels. You have to monitor blood pressure. And in overdose, SNRIs can be more cardiotoxic than SSRIs. It's a more powerful drug, and with power comes a bit more risk.
Good to know. Now let's step back in time to strategy 3, the heavy artillery. The TCA's tricyclic antidepressants. Amitriptyline, imipramine, nortriptyline.
I like the term heavy artillery, or maybe the shotgun approach. Chemically, they are 3-ringed structures, hence tricyclic, and Kasetsum rightly describes them as dirty drugs.
Dirty in pharmacology usually means they hit a lot of receptors they aren't supposed to, right?
So
They're not
that's
selective.
Exactly. They act like SNRIs. They block serotonin and norepinephrine reuptake, which makes them highly effective antidepressants. In fact, some argue they are more effective than SSRIs for severe inpatient-level depression.
Ugh.
But because of their chemical structure, they also unintentionally block 3 other major receptor types: H1 histamine receptors, muscarinic cholinergic receptors, and alpha-1 adrenergic receptors.
And this is where we map the side effects. We talk about side effects as mechanics. This is the part that helps listeners remember this stuff without flashcards. Let's break this down. If a TCA blocks H1 histamine receptors, what happens?
Simple. Think about what happens when you take an antihistamine like Benadryl, which is diphenhydramine.
You get sleepy, very sleepy.
You get sedation. And with chronic blockade, the brain's satiety center gets confused, leading to significant weight gain. So, sleepy and hungry.
Okay, that's one. Now, if it blocks muscarinic cholinergic receptors, what does acetylcholine do?
Acetylcholine is the wet neurotransmitter. It's part of the parasympathetic rest and digest system. It makes you salivate, it helps you pee, it helps your gut move, it constricts your pupils.
You block it.
You get the classic anticholinergic toxidrome. We have a saying to remember it: blind as a bat, dry as a bone, red as a beet, mad as a hatter.
Translating that to the patient experience.
Blurred vision because the pupils can't constrict, severe dry mouth, constipation because gut motility slows down, and urinary retention. Plus, in the elderly, it can cause confusion and delirium.
Ouch. That's a lot. And the third one, alpha-1 adrenergic blockade.
Alpha-1 receptors are on your blood vessels. Their job is to squeeze the vessels to maintain blood pressure, especially when you stand up.
Right, to fight gravity.
Exactly. If you block them, the vessels relax and dilate. So when the patient stands up, gravity pulls the blood down to their legs. Normally, alpha-1 would squeeze the vessels to push blood back up to the brain. Since it's blocked, the blood stays down, blood pressure drops, and they get dizzy or faint. That's orthostatic hypotension.
So sedation, weight gain, dry mouth, constipation, and fainting. Why on earth do we still use these drugs?
2 reasons. 1, because they work. For severe treatment-resistant depression, they are powerhouse drugs. And 2, like the SNRIs, they are excellent for pain. Amitriptyline is a staple for chronic pain management, migraine prevention, and insomnia.
So you use the side effect.
You use the sedation, but you use it at much lower doses where those other side effects are more manageable.
But safety is a real issue here. Katzone warns about overdoses.
Yes. This is critical. This is maybe the biggest reason they aren't first line. TCAs are lethal in overdose. A 1-week supply can be fatal. They block cardiac sodium channels, causing arrhythmias, and they cause coma and seizures.
So for a depressed patient with suicidal ideation.
That's a very dangerous prescription. A 2-week supply of Prozac might just make you very sick, but it likely won't kill you. That's a massive consideration for prescribing.
Huge. Okay, moving to strategy 4, the original and the atypical. Let's start with the MAOI's monoamine oxidase inhibitors.
These were the first antidepressants discovered almost by accident in the 1950s, and they have a totally different mechanism. Instead of blocking reuptake, which is the vacuum cleaner.
They poison the janitor.
Yes, they inhibit the enzyme monoamine oxidase that eats up the neurotransmitters in the nerve terminal. It's like welding the drain of the sink shut so it fills up.
But there's a famous danger here, the cheese effect.
Ah, yes, the cheese effect. It sounds funny, but it's deadly serious. Monoamine oxidase, or MAO, is not just in the brain, it's also in the gut and liver, where its job is to break down toxic amines from our diet before they get into our system.
And one of those is tyramine.
One of those is tyramine found in aged cheese, red wine, cured meats, pickled fish, soy sauce, fava beans.
So if you were on an MAOI, and you eat a charcuterie board.
The MAO in your gut is inhibited. It can't break down the tyramine. The tyramine gets absorbed, enters the bloodstream, and it acts as an indirect sympathomimetic. It gets taken up into your nerve endings and causes a massive dump of norepinephrine.
And that leads to?
Your blood pressure skyrockets, a hypertensive crisis. You get a pounding headache, and you can have a stroke or a heart attack.
So no wine and cheese parties for MAOI patients?
Strictly forbidden. It requires a very strict diet. That is why MAOIs are a third-line treatment, reserved for only the most resistant cases where nothing else has worked.
Now let's talk about the atypicals, specifically bupropion. I've heard this called the undepressant.
Bupropion is fascinating because it breaks the serotonin rule. It doesn't touch serotonin. It weakly inhibits the reuptake of norepinephrine and dopamine.
So no serotonin means.
No serotonin side effects, no sexual dysfunction, and no sedation or weight gain. In fact, it's activating. It gives energy. It feels more like a stimulant.
And it's used for smoking cessation too, right? Under the name Zyban.
Yes. Likely due to the dopamine effect on the reward pathways in the nucleus accumbens, it helps with the craving by mimicking some of nicotine's effects on dopamine. It's a great drug for a depressed patient who is sluggish, worried about weight gain, or concerned about libido.
Is there a catch? There's always a catch.
It lowers the seizure threshold. So if you have a patient with a history of seizures or an active eating disorder like bulimia, where electrolyte imbalances already risk seizures, bupropion is absolutely contraindicated.
Okay. And on the flip side of activating, we have the highly sedating atypical mirtazapine.
Mirtazapine is a unique beast. It has a complex mechanism. It blocks presynaptic alpha-2 receptors, which are brakes on the system, so it forces the release of more serotonin and norepinephrine.
So it's like cutting the brake lines.
Right. But critically, it also potently blocks H1 histamine receptors.
And H1 block equals sedation and weight gain, just like the TCAs.
Exactly. Which sounds like a side effect, but clinical reasoning turns it into a benefit. Imagine an elderly patient with depression who has severe insomnia and has lost 20 pounds because they have no appetite.
This is the perfect drug for them.
You give them mirtazapine. The sedation helps them sleep. The appetite stimulation helps them eat and regain weight. The side effect is the therapeutic effect. That is the strategy over lists concept in action. You aren't just treating depression, you are treating a specific person with a specific profile of symptom.
Precisely. Okay, we've covered the antidepressants, the long game of neuroplasticity. But often, we need to treat anxiety more acutely. That brings us to Section 3, the mechanics of calming sedatives and anxiolytics.
Here, we shift our focus from serotonin and norepinephrine to the king of inhibition, GABA.
GABA, gamma-aminobutyric acid, the brain's primary inhibitory neurotransmitter, the off switch.
Or maybe the dimmer switch. The GABA-A receptor is a fascinating machine. It's not a G protein-coupled receptor. It is an ion channel. Specifically, a chloride channel.
Okay.
When GABA binds to it, the channel opens, and chloride ions, Cl, which are all over the outside of the cell, rush into the neuron.
And chloride is negatively charged.
Right. So when a flood of negative ions rush in, the inside of the neuron becomes more negative. We call this hyperpolarization.
And a hyperpolarized neuron is?
Harder to fire. It moves further away from its activation threshold. It effectively quiets the noise in the brain. It's the brain's natural brake.
Right. And the main drugs we use here are benzodiazepines, diazepam, alprazolam, lorazepam, Valium, Xanax, Ativan.
These are the gold standard for acute anxiety, panic attacks, alcohol withdrawal. But how they work is a critical distinction. Do they just pry the channel open themselves?
I would assume so. They're agonists, right?
No, and this is a key point. They are positive allosteric modulators.
Okay, break it down.
Allosteric means they bind to a different site, a specific side pocket on the receptor, not the main GABA binding site. And modulator means they don't open the channel themselves. They just make the receptor more sensitive to GABA. They increase the frequency of the channel opening when GABA is present.
And they amplify the body's natural braking system. They don't slam the brakes themselves. They just make the brake pedal more sensitive.
Exactly. And this implies a ceiling effect. They can only work as much as there is GABA available to open the channel. This makes them relatively safe compared to the older drugs, the barbiturates.
Kitsune has a fantastic graph comparing these two barbiturates versus benzodiazepines. It's the safety curve.
It's a terrifying graph for barbiturates. It shows a linear dose-response curve. As you increase the dose of a barbiturate like phenobarbital, you go from sedation to hypnosis to anesthesia to coma to respiratory depression and death in a straight line.
Why? Why don't they plateau like the benzos?
Because at high doses, barbiturates act differently. They can open the channel without GABA being present. They don't just modulate. They act as direct agonists. They can also block glutamate receptors. So they don't need the natural brake. They just flood the engine and shut everything down.
They can shut the brainstem down completely.
Which is why they are so lethal in overdoses, especially when combined with alcohol.
Whereas the benzodiazepine curve on that graph.
It plateaus. It flattens out. It's much harder to reach lethal anesthesia levels with benzos alone because they are limited by the amount of GABA in your system. They need the driver's foot to be on the brake pedal. They can't push it themselves.
That explains why barbiturates have mostly disappeared from general practice, except for specific uses in anesthesia or epilepsy. Now, what about the Z drugs? Zolpidem, ambien-zolpidem, azopiclone. These are the modern sleep drugs.
Structurally, they aren't benzos, but they act on the same GABA receptor complex. However, they are highly selective.
Selective for what?
The GABA receptor has different subunits, alpha 1, alpha 2, alpha 3, etc. Different subunits mediate different effects. Benzodiazepines are non-selective. They hit them all. That's why you get sedation, anxiety relief, muscle relaxation, and anticonvulsant effects.
It's a broad approach.
A very broad approach. But the Z drugs bind primarily to the alpha 1 subunit, and this subunit is specifically linked to sedation.
And what does that selectivity get us? What's the benefit?
It gets us pure sleep induction hypnosis with much less of the muscle relaxation or anticonvulsant or anxiolytic effects. There are surgical strikes for sleep. You get the sedation without all the other baggage.
But they come with their own weirdness. I've read about complex sleep behaviors.
Yes. Sleep driving, sleep eating, sleepwalking, people doing complex tasks while essentially unconscious and having no memory of it the next day. It's rare, but it's a black box warning on these drugs. It seems related to that specific alpha-1 activation disconnecting conscious control while motor circuits remain active.
It's the scary stuff. So we have the antidepressants for the long game and the sedatives for the short game. Section 4 is where the rubber meets the road. Clinical integration, the art of prescribing.
This is where we take all that mechanism and apply it to a human being. Because patients don't walk in saying, I need a selective serotonin reuptake inhibitor. They walk in with a messy life and a cluster of symptoms.
Let's run through some scenarios. We touched on a few, but let's solidify them. Scenario 1. You have a 55-year-old patient with major depression, but they also have debilitating chronic neuropathic pain from diabetes.
Clinical reasoning says, don't just give an SSRI. It might help the mood, but it won't touch the pain. You reach for an SNRI like duloxetine, or perhaps a TCA like nortriptyline if the SNRI isn't tolerated or affordable. You treat the mood and the pain with one agent. It's efficient and logical.
Scenario 2. A 78-year-old patient in a nursing home who is depressed, anxious, has terrible insomnia, and has lost 10 pounds in a month from lack of appetite.
Mirtazapine. It's almost purpose-built for this patient. We discussed this. You use the potent H1 histamine blockade to your advantage. The sedation helps them sleep through the night. The appetite stimulation helps them regain weight. If you gave this patient fluoxetine, Prozac, which can be activating and suppress appetite, you might make the insomnia and weight loss worse.
Right. It would be pharmacologically tone deaf.
Exact.
Scenario 3. A young professional, 30 years old, with their first episode of depression, they're terrified of sexual dysfunction because it will ruin their relationship. This is their primary concern.
You listen to that. You avoid the SSRIs as a first choice. You go to bupropion. It works on dopamine and norepinephrine, sparing the sexual pathways. Or you might use mirtazapine, which blocks the 5-HT2 and 5-HT3 receptors, which can actually mitigate some of the serotonergic sexual side effects.
Yeah.
You tailor the choice to the patient's priority.
And a final one, scenario 4, panic attacks. A patient comes into the ER feeling like they're dying right now. Heart racing, sense of doom, hyperventilating.
Acute distress needs acute relief. An antidepressant won't work for weeks. So you might prescribe a short course of a benzodiazepine for immediate relief, a fire extinguisher to put out the immediate fire.
But you can't just leave them with the fire extinguisher.
No, because that's not a long-term solution. You have to have an exit strategy. You simultaneously start an SSRI for the long-term prevention of future panic attacks. The SSRI is the new sprinkler system. Ideally, you taper off the benzo once the SSRI kicks in and the neuroadaptation happens.
Now, we have to talk about the black box warning. It's on all antidepressants. Risk of suicidal thinking in young people, specifically under age 25.
This is a counterintuitive and tragic phenomenon, but understanding the lag and the mechanism of action actually explains it.
Why would a drug designed to treat depression cause suicidal thoughts? It seems so paradoxical.
The prevailing theory goes back to the timeline of recovery. The different symptoms of depression don't all get better at the same speed. When you start treatment, energy and psychomotor speed often improve before the low mood and hopelessness lift.
Oh, I see. So you have a patient who was previously so lethargic, so anhedonic, that they couldn't even get out of bed to act on their dark thoughts.
They were essentially frozen in their depression. But suddenly, 2 weeks in, the drug gives them the energy to plan and execute, but they still feel the deep despair and hopelessness because the mood hasn't lifted yet.
And that creates a window of terrible vulnerability.
A very dangerous window. Usually in the first 2-4 weeks of treatment, It requires close monitoring. It doesn't mean you don't use the drugs. It means you watch the patient like a hawk during that initial period.
That is a critical insight. It's not that the drug makes them suicidal, but it changes the dynamic of their symptoms dangerously for a moment in time.
Exactly. It disinhibits the behavior before it fixes the core mood.
Let's touch briefly on sleep hygiene and drug limits. We talked about Z-drugs and benzos for sleep. They seem like a magic bullet.
They can feel like it, but the rule is, drugs are not a substitute for behavioral changes. Katzung emphasizes that sedatives change your sleep architecture. Benzos, for example, decrease REM sleep and deep, slow-wave stage 4 sleep.
So you are unconscious, but you aren't getting restorative, good sleep.
Correct. It's light, fragmented sleep. And if you stop abruptly after chronic use, you get rebound insomnia. Your brain, which has been fighting against the sedative for so long by upregulating its own wakefulness pathways, swings back into hyperarousal. Sleep gets even worse than it was before you started.
So use sparingly and short-term is the mantra.
Absolutely. And tolerance develops quickly. Within weeks, the same dose doesn't work as well, leading to dose escalation and dependence.
We're heading into the home stretch. Section 5, New Frontiers and Synthesis.
Yeah.
We can't ignore the new kid on the block, the one that's changing the game. Ketamine.
Right. Goodman and Gilman mentions ketamine as a target for NMDA glutamatergic receptors. This is the new frontier. It's a completely different approach.
This breaks all the rules we just spent an hour talking about.
Right.
It's not monoamine-based at all.
It does. It produces rapid antidepressant effects, sometimes within hours of a single infusion. It completely challenges the lag time dogma because it works through a completely different pathway, glutamate, the brain's main excitatory neurotransmitter.
And how does it work so fast?
The thinking is that it causes a burst of glutamate release, which then leads to a rapid increase in BDNF and synaptogenesis. It seems to trigger that synaptic plasticity, that fertilizer release, much, much faster than the monoamine drugs.
It acts almost like a reboot for the system, a burst of plasticity.
Exactly. It's still being integrated into practice primarily for treatment-resistant depression and acute suicidality, but it's a sign that the field is evolving beyond the monoamine hypothesis.
It brings us back to the synthesis of concepts. Treatment isn't just about balancing a checkbook of chemicals. When you boil it all down, it is about plasticity.
Yes, moving the brain from a stuck, stressed, rigid state to a flexible, adaptable state where it can learn and grow again.
In balance. Balancing the neurotransmitters, serotonin, norepinephrine, GABA, to create the right chemical environment where that structural repair, that plasticity can finally happen.
That is the essence of it. Pharmacology is a tool for resilience, not a cure in a bottle, but a tool to help the brain's own resilience mechanisms get back online.
I love that. Which brings us to our outro and a final provocative thought to leave our listeners with.
Okay, here it is. If the true healing, the actual cure, comes from neurogenesis and synaptic remodeling, from growing new connections, which takes weeks, are the medications just permission slips for the brain to heal itself?
That's a deep thought. It implies that the drug doesn't do the work. The drug simply allows the work to be done. It creates the conditions for healing.
And if that's true, how does that change our view of other interventions, like talk therapy, or exercise, or mindfulness? If those things also stimulate BDNF, and evidence shows they do, then talk therapy is actually a biological intervention. It physically reshapes the brain alongside the drugs.
They're all just different ways to fertilize the same garden. Different tools for the same job.
Exactly. The drug prepares the soil, but the therapy and the life changes. Plant the seeds and tend the garden. It has to be a combined approach.
Well, on that note, we have covered a lot of ground. From the gardening metaphor, to the dirty TCAs, to the cheese effect.
It's a dense topic, but a vital one. Understanding the why makes all the difference.
I want to encourage you, the listener, to open Katzung chapter 30 and Goodman and Gilman chapter 15. Don't just read the words. Look at the chemical structures. Look at the rings. See the difference between the messy three-ring structure of a TCA and the clean structure of an SSRI. It really helps the concept stick.
Visualizing the molecule helps you visualize the mechanism. It all starts to click.
Thanks for diving deep with us today. Stay curious.
And keep learning.
We'll see you on the next deep dive.